Hello and welcome to the California Society of Anesthesiology online first episodes. Today, our topic is the American Academy of Pediatrics Clinical Practice Guidelines on acute pain management and opioid use in children. This is a major milestone in pediatric care guidelines, and our guest speaker is Dr. Rita Agarwal. With over 67,000 members, the AAP's endorsement underscores the importance of this guideline, and it applies to anyone who's prescribing opioids for children. This was developed over 5 years with a multidisciplinary team. It is hugely important for all fields in pediatric subspecialties and primary care. This panel it is co-chaired by Dr. Rita Agarwal, who is a pediatric anesthesiologist at the Lucille Packard Children's Hospital, and Dr. Scott E. Hadland of Massachusetts General Hospital. These guidelines are really important for all pediatric healthcare professionals. Dr. Agarwal, what motivated the creation of these guidelines, and how do they address the unique challenges of managing acute pain in the outpatient setting?
First of all, thank you so much, Carol, for inviting me to speak on this, and also for that really lovely introduction. So I'm glad you asked the question, because a number of years ago, we were at the height of the opioid epidemic. At the time, the opioid epidemic really wasn't thought to apply to children. It seemed to be something that was occurring to adults. There was a small group of us within the AAP and the SPPM who were very concerned about this also being a pediatric problem. At the same time, we were concerned that people were increasingly uncomfortable prescribing opioids on the one hand and not treating pain adequately. And on the other hand, there was still an excessive number of opioids being prescribed to some patients, particularly those going home after surgery or after an acute injury of some kind from the emergency room. So Dr. Ray Brown is actually the person who really pushed for these and really lobbied and advocated with the American Academy of Pediatrics to create these guidelines. Nothing existed similar to this at the time that was specifically aimed at pediatricians or others who wrote prescriptions for pediatric patients. So that is really what motivated it. He, at the time, was the chair of the section on anesthesiology and pain management for the AAP, and I was the immediate house chair, and I think at the time I may have been president of SPPM, but that's how it kind of all got off the ground. It took a few years for the AAP to decide they wanted to do this, and then to assemble a multidisciplinary expert panel to proceed with this.
I believe those guidelines were visionary. We see this problem really is a problem of the pediatric population, and it should be not ignored. So besides you and Dr. Scott, who else is on the expert panel, and what did they bring to the table?
So we worked really hard to make sure that we had representatives kind of from all fields. Dr. Bob Wilder, who's also past president of the SPPM, representing anesthesia and pain medicine. Dr. Hadland is an addiction specialist and a pediatrician. We had emergency room physicians. We had 2 pediatric surgeons. We also had experts in implementation science and epidemiology and in guideline creation, people who've gone through this and know what it takes to create effective guidelines. So we had a range of people with different backgrounds and viewpoints to really bring together to try and create something that pediatricians and others who prescribe opioids could use.
I'm very impressed. So the document and the guidelines itself are actually quite impressively comprehensive. So we're going to break it down into the different key action statements one by one. And I'd like to get your thoughts and your summary of the key action points. So let's talk about the first key action statement, multimodal approach.
We did pretty extensive literature reviews. And I want to first start off by saying there often isn't a lot of really strong evidence in the literature. This one was pretty good literature to really support that. A key action statement 1 is to use a multimodal approach. And the idea, of course, is very similar to the stepwise guide of pain management. You start with things like acetaminophen or paracetamol, and then move to stronger nonsteroidals such as ibuprofen or Celebrex or some of the other nonsteroidals that are out there. You also, with the multimodal approach, we really intended it to mean approach and not just medications. So that includes things like cold, heat, stretching, all of the different approaches. We included, I think, as part of our examples, things like cognitive behavioral therapy, relaxation therapy, meditation. All of those kinds of things should be used as a more holistic approach to pain management.
This is an important recommendation or key action statement. There is a statement that says you should avoid codeine and tramadol. Can you elaborate?
The FDA put out black box warnings a few years ago that really recommended against the use of codeine and tramadol in children under the age of 12. There is enough variability in how these drugs are metabolized in the liver that can cause either no analgesic effect or too rapid of an analgesic effect, and has led to many case reports of fatal side effects with these drugs. In children aged 12 to 18 and or children undergoing tonsillectomy in that age range, they're again kind of warned against, and this is again FDA recommendations, and so we really just elaborated on those recommendations.
Another key action statement is caution with sedating medication.
The idea behind this is that in some patients who may be going home with an opioid either after surgery or some kind of acute injury that leads to acute pain, they may actually benefit from some other medication that can have as a side effect sedation. So for example, a benzodiazepine in a patient who's either extremely anxious or is having a lot of muscle spasm, they may benefit from low dose benzodiazepine. The point is that we don't want them to just willy-nilly be given, a bottle of Valium and a bottle of oxycodone and sent on their way. We want pediatricians and again, others who prescribe to very intentionally think about how much of each, what doses, and what potential interactions may occur. And it's not just benzos, it's other things like muscle relaxants can also cause sedation. And so the idea is, just to be really thoughtful about how these drugs are prescribed.
The action statement on naloxone is something I think is a very important message that we have to get out to practitioners. Can you elaborate on the provision of naloxone?
This is one of the things that we really hope to get across. There is no evidence for this. We scoured the literature, both adult and pediatrics. There is no randomized controlled studies. Most of the use of Narcan is anecdotal. There is a recommendation that if you're giving either more than, I think it's 5 days worth of an opioid, or if you're sending them home with another sedating medication, that you should prescribe naloxone for that patient to go home with. We just took it a step further and said, if you're sending a child home on an opioid, send them home with naloxone too. Write a prescription, or if you have it available in your office, in your practice, send them home with naloxone, because we know that it's not just about the patient who's getting the medication. It's also about everyone else in that family who lives in that home. That could be a toddler who gets into the medication inadvertently and takes an overdose. That could be a friend of the patient, or it could be, the sibling of a patient whose friends come over. We just don't know. The issue is, and we didn't just say send them home with naloxone. We also said review the signs and symptoms of overdose and what to do if that were to occur. Because the one thing that we know that is absolutely 100% life-saving is naloxone in a case of opioid overdose. So in our expert opinion as a group, we felt like there was very little harm in making this recommendation and potentially a huge amount of gain in making the recommendation. So we just made it as a blanket statement.
The next two key action statements seem like they should be together, but actually they're separate. But I agree that they are very common sense. One is education on safe storage and administration, And the other one is educate on safe disposal. Now, they're separate, but they're very important. Can you elaborate?
Right. And I tend to actually think of the three, naloxone, safe storage and usage, and disposal, as kind of being three very interrelated key action statements, in that the goal is that there is a conversation with the family. We don't just hand them the medication. We just, we say, this is the opioid. It's very important that you keep it in a locked location, if at all possible. It's not always possible for people, but that you keep it safe, you keep it locked. If you can, keep it up and out of the way, especially if there are small or young children in the house, so that they don't inadvertently get into those medications. That you observe the child when they're taking the medication. You don't just give them the pills and say, here, take it when you need it. You watch them actually take it, and you make sure they get the correct dose at the correct time. The other one then is on safe disposal, assuming that there's any left of either the opioid and or if there's any other controlled substances. It's incredibly important to have a plan on how to dispose of it, because it's too easy just to say, oh, well, if you have any left over, you can take it back at a take-back day, at a DEA take-back day. That's true. It's interesting because it's actually changed. It used to be the FDA really recommended flushing everything in the toilet that was compatible, and opioids and benzos were compatible with being flushed. But because people don't like the idea of opioids in their water supply, that just didn't gain the traction that they wanted it to. So now the push is return it somewhere. There's websites, there's local websites. In California, we have Don't Rush to Flush is a website where you go in, you can put in your zip code and what kind of medication it is that you're trying to dispose of, and it'll give you a list of places close by to you, because a lot of pharmacies take back some medications, but not all. A lot of, like, Walgreens, the Walgreens closest to me does not take back, and closest to you, I don't think takes back it doesn't take back opioids. I know that for sure. I don't know if it takes back other uncontrolled substances. There's police stations that will take back opioids, but not all of them. There's sheriff stations, there's fire stations that have the capability to do this, but not all of them. Some of them may have only certain times, because oftentimes if it's an opioid or a controlled substance being returned, that location has to be manned. There has to be somebody there to help with that in terms of where to return these meds. There's several increasing pushes to create medications that sort of self-destruct when you're done with the usage of it, or where you can self-destruct it, or charcoal activated envelopes where you can put the medication in it and return it back to the institution that prescribed it in the first place. AAP encourages pediatricians' offices to try and be a take-back location. That's actually a lot of work to do, and it's probably not, at least at this time, quite practical yet. But it's something to think about for the future. If we, by the way, at LPCH are not a take-back location. We don't take back anything.
So this article and guidelines are titled Opioid Guidelines, but a key action statement is consider alternate to opioids. Can you elaborate on this?
Yeah, so again, the idea really is, I think the ultimate idea when we set up our PICO statements was to consider what is our ultimate goal. And the ultimate goal really is twofold. One is to make sure that opioids are prescribed when it's appropriate, and that when they are prescribed, they're prescribed safely. And that as much as possible, we can minimize any harm that can come from them. But at the same time, we also know that there's a lot of situations where opioids may not be required. Increasingly, there's evidence that things that in the past we always just routinely prescribed an opioid for probably don't need an opioid. It's just that, we've sort of swung from a culture that tolerated pain to not tolerating any pain to back to saying, oh wait, maybe we should rethink this. So for example, third molar surgery or wisdom teeth surgery, that was one where routinely patients went home with some kind of an opioid, whether it was, when I had mine out, it was Tylenol with codeine, or whether it's a, Vicodin or, hydrocodone combination or an oxycodone combination. Increasingly, studies are showing that really all they need is around the clock acetaminophen and ibuprofen, and patients should do just fine. So I think there's going to be, I know a lot of surgeons, particularly in Michigan, a lot of this work has been done where they're looking at types of surgeries that really may not require opioids that are going home with it anyway, to try and recommend either a decrease in prescription or no prescription at all. So the twofold goal of our guidelines really is to make sure that when they're prescribed safely, but to look for alternatives so that maybe you don't need any opioids, or maybe you can use less opioids. But we don't want patients to suffer. And I think what we saw happening was that there was a lot of, oh, well, we can't use opioids in children, or we can't use opioids in this patient population, therefore we're not going to give them anything for pain. So we really didn't want that to happen.
Thank you, Rita, for your work and your promotion on these guidelines. I think they're going to be amazing for not only pediatricians, but for all pediatric subspecialties. And they strike the right balance that you mentioned, from going from avoiding opioids and probably causing harm from more pain to prescribing too much opioids and not realizing how to moderate safely the dosage of opioids and how to give it, as well as how to get rid of it. So fantastic, amazing work. And thank you for your time. And this was wonderful. Thank you.
Thank you, Carol. Thank you so much for inviting me.
Great work.